We can get going here. My name is Brian Conway from Simon Fraser University, Vancouver Infectious Disease Center. Pleasure to be co-chairing this session, this clinical session of the Canadian Symposium. Okay, as we grab our seats here, we're used to having some American participation. This was alluded to before. And we're glad to have our returning exile Mohammed and the lifelong rebel John Ward here with us, representing the United States. I have breaking news, guys, is that it came on the web this morning that Donald Trump has petitioned the Canadian government to have the United States become the 11th province of Canada. And je me réjouis du fait qu'à partir de la semaine prochaine, M. Trump va prendre des cours de français. Okay, donc as Mr. Trump takes his French lessons next week, and of course he will become fluent in the language in 1 week, never been done before, first time ever, exceeding all expectations, that the situation will have normalized itself in terms of science by next year. So, and you can see everything that I've said is obviously, not fake news. You can see it at the website alternatefacts.com. And okay. So there you go. I will now ask my co-chair to introduce the first of our plenary speakers.
Hello, everyone. It's my pleasure to introduce our first speaker for this session, Dr. Guillaume Fontaine. He is assistant professor at McGill University. As an implementation scientist, Prof. Fontaine navigates the complex terrain of bringing scientific advancement into everyday use, devising strategies to overcome barriers, and ensuring that research findings effectively enhance healthcare and societal outcomes. His research focuses on the methodological approaches used throughout implementation research to support adoption, penetration, sustainability of evidence-based interventions, practices, programs, and policies in healthcare, with a focus on infectious diseases and equity-deserving population groups. Over the last few years, he has worked with leading implementation scientists in Canada and Australia, using novel approaches from implementation science to establish and improve provincial and national initiatives focused on the diagnosis and treatment of infectious diseases such as hepatitis C.
Thank you so much for the introductions. I'm really going to give a quick overview of some of the initiatives that we are working on around scaling up point-of-care testing for hepatitis C infection. So here are my disclosures. So as we all know, a major barrier to increasing the uptake of hepatitis C testing and treatment is the current diagnostic pathway, leading to loss to follow-up. We have, most times multiple visits, one for antibody test, phlebotomy, receiving diagnosis for a separate visit, phlebotomy again for RNA testing, and then another visit. So this poses a major challenge to increasing treatment uptake and achieving elimination targets. We also have additional barriers among priority populations that are amplified in those with the highest burden of HCV in Canada, including people who inject drugs, which represent 85% of new infections, and those in prison as well. As you all know, people who inject drugs face stigma, discrimination, inadequate health services access, poor venous access. So those are additional barriers for this population. And also people in prison are often released prior to their antibody or RNA results. So we have an urgent need to leverage innovations across the care cascade to streamline the diagnostic pathway, enhance access to hepatitis C testing and treatment. So we completed a systematic review and meta-analysis in the Lancet Gastroenterology and Hepatology a few years ago, looking at a range of interventions to enhance the care cascade for hepatitis C. So around 30, 35 interventions. And most promising interventions were focused around the simplification of testing. So point-of-care antibody testing had key effects on linkage to care treatment initiation, just like point-of-care RNA testing as well, dried blood spot testing, reflex RNA testing, and opt-out screening as well. So taking those evidence-based interventions into consideration, we have to think about how do we translate those most effectively into practice. And this is how implementation science comes into the dance. So of course, HCV elimination is not just a biomedical clinical challenge, but mostly, right, an implementation challenge. Because we have effective tests and treatment, but they're not reaching everyone who needs them. So implementation science is really looking at what works, why, for whom, and under what circumstances. And we know as well that if we're going to implement some of those interventions on a larger scale, stakeholders across multiple levels of the healthcare system need to change their behaviors and decisions, and this is when working in complex environments, under-resourced environments as well. And we have tools and resources in implementation science to help us do that and support change. This is highlighted, so we have a short paper coming out in Lancet Gastroenterology and Hepatology around the urgent need for implementation science to achieve elimination. So if you're interested in knowing more about some of the different ways that we can leverage implementation science to help out with HCV elimination, including tools that can be leveraged by clinicians, I encourage you to read this when it's going to be coming out in a few weeks. So, a few examples of how we can apply implementation science to look at what works for whom under what circumstances is the Australian point of care testing program. So I'm a visiting fellow at UNSW Sydney, so I've done a few stays in Sydney, Australia, to look at the Australian hepatitis C point of care testing program, which has now been running up for 3 years. And Jason Grebley, the PI for the program, has just received $10 million from the federal government of health to renew the program for 2 additional years. So this is pretty encouraging because they're going to be able to scale the program even more. So this program is now established across drug treatment clinics, needle and syringe programs, prisons, mental health clinics, a lot of mobile outreach models, homelessness services, Aboriginal health organizations as well. It includes different things. So we have standard operating procedures, logistics, support for deployment of point-of-care antibody and RNA testing on a large scale, a really solid operator training program, a quality assurance program, support as well for IT and connectivity to enable efficient data transmission, and also a research and evaluation framework. So as of now, there's 104 sites, and you can see across Australia some of the prison sites where they're located and the community sites. And around those sites, there's around 400 testing locations. So and the plan is to scale up to 120 sites by next year. So this is the January update. So one thing that is great within the national program is they're very effective at communication with different stakeholders. So they have monthly updates that are really detailed and that use some strategies around peer pressure, social norms to enhance competition among sites. So that's pretty interesting. But essentially they've completed almost 37,000 tests, almost 12,000 antibody tests, 25,000 RNA tests, and almost 31,000 unique individuals receiving testing. And then you can see below the number of individuals initiating treatment. The treatment uptake within 12 weeks is at 77%, so lower in the community, higher in prison, and now represents, and that's an increasing proportion, 10% of all HCV treatment in Australia, and almost a quarter of all treatment in the state of Queensland. So I came in, a few years ago, looking at doing some implementation research within the Australian National Point of Care Testing Program to look at what works for whom and under what circumstances. And we are conducting an implementation science informed study, a mixed method study that's guided by the Consolidated Framework for Implementation Research, which is really a way to systematically look at the factors influencing implementation of a new program or intervention. So we've coded all protocols, operating procedures, training materials pertaining to the national program. We are coding all meetings of the national program that have occurred since 2021. So we're up to 125 meetings that were coded using implementation science frameworks and tools to look at the barriers and facilitators and the factors of influencing the success of the program. And we also completed 30 interviews with stakeholders in government, policy, the Ministry of Health, industry, providers, research stakeholders to look at, what are the key factors influencing success. So there's a lot of data that I can tell you. So we're sorting out through all of that data. So we've identified 693 unique factors influencing the success, the implementation of the program, barriers and facilitators. So that's what the latest abstract says, but we'll see how that goes with the next round of analysis. But essentially, some of the key barriers, for example, are, there's a perceived complexity, logistics of the gene expert point of care testing machine that's quite complex, and there's a QA process as well to handle that's often not so simple. The lack of sustainable funding, the lack of financial incentives in some instances, shortages around staff, of course, workflow integration challenges, operator capability and motivation, a lot of tricky situations around IT data connectivity, and the paperwork and data entry as well. So we're looking at factors across those 5 domains. So the point of care testing in itself, health system and policy, the different clinics and workplace factors, patient, clinician, staff perspectives, and also factors pertaining to the implementation process in itself. And also we're looking at what are the key implementation strategies, the strategies enabling success in the program. And what we found is that really the early and continued stakeholder engagement is critical. There's a lot of leadership and advocacy at different levels of the government with key people in place. They've set up the program in a way to identify and work with early adopters across different states, and that enabled early buy-in. They've done a comprehensive site readiness assessment. They've worked to stage implementation scale-up as well in different waves to control problems occurring along the way. Like I said, solid QA and training programs and ongoing technical support. But this is just a small snapshot of what we are working on. And then we're developing an implementation research logic model, which essentially in a very, very high level, just for illustrative purposes, is going to map out, the clinical intervention and the workflow around point of care testing, the different barriers and facilitators that we found, the implementation strategies, the mechanisms of actions of those strategies, the implementation outcomes in terms of higher reach, adoption of point of care testing, timeliness of services, and then client outcomes. So this is, in a way, going to be a blueprint for us to work in other contexts to help scale up point of care testing and learn from the program. So briefly, I don't know how much time I have left. Okay. So we just had funding last year to do some, essentially, what can we do in terms of initial work in Canada to potentially help scale up point of care testing for hepatitis C. So we put together a grant that was successful last year. So this is a study looking at the clinical processes, barriers, facilitators, and implementation strategies for scaling up point of care testing. We have a fantastic team across 3 provinces, many partners that are in the room today as well. So we're just getting started with this study. So this study aims to generate implementation evidence to help inform the scale-up of point of care testing in Canada. First objective is looking at mapping out workflows and decision points and operational processes in current models of HCV care, and also working with sites to work around proposed and optimal models of care around point of care testing using process mapping. And then the second objective is looking at the barriers and facilitators to implementing point of care testing at different levels. I'm going to talk a bit more about that. And then the last 2 objectives pertain to co-designing with sites that are in the study different strategies, materials, protocols to support the uptake of point of care testing that are going to be fed back to the sites that are partnering with the study. The first method that we're using is implementation science process mapping. So we're working with sites, sitting down with a needle and syringe program, mapping out in detail what is the current model of care, how are the tasks related to client identification, to point of care antibody testing, to RNA testing, linkage to care, treatment uptake are linked together. We're looking at the barriers and facilitators using an implementation science framework along those steps. And we're also augmenting those process maps with clinical audit data to look at the number of people antibody tested, RNA tested, and where the gaps are, essentially. So that's the goal. And we're working with around 25 sites, that's the goal. So 5 to 6 prisons across BC, Ontario, Quebec, 5 or 6 Indigenous health organizations, needle and syringe programs, outreach models, and 5 or 6 other models of care that maybe offer more wraparound services, addiction medicine clinics. And we come in the discussion with a basic process map for point of care testing that is going to be personalized and tailored to each site. And that's going to be it's going to be a personalized tool for each site, essentially. And then a bit of a plug. So we're just starting the study, but we want to interview as well as part of this study 60 decision makers, 30 decision makers around point of care testing. So people that hold a position in local, provincial, national government, health authority that might influence HCV testing and treatment policies. And we also are looking to interview 30 laboratory and quality assurance stakeholders at different levels to gather evidence and engage stakeholders at different levels around point of care testing. So if you have some people in mind, you can come and talk to me. In conclusion, so the current diagnostic pathway remains a major barrier to HCV testing and treatment, particularly for equity-deserving groups. I strongly believe that implementation science provides a structured approach for overcoming these barriers, working with community members and clinical practice settings to identify what works, why, for whom, and under what conditions. We can learn a lot from the Australian Hepatitis C point of care testing program at different levels, and we're going to need to leverage all of that knowledge to develop tailored strategies to support the uptake of point of care testing, and that's going to take a lot of work. But that's also an exciting opportunity. So thank you, and a few credits for the slides to Jason Gruber.
Thank you, Guillaume. We'll take 2 questions. There's one right over here.
Hi, I'm Susan Kuvler. I'm hepatitis figure in Manitoba. Thank you. Hi, I'm Susan Kuvler from Manitoba. A comment and a question. They're kind of both questions. First, there was no mention of the impact of racism on treatment in Australia. Do you think that that was an impact? And secondly, in your plans for interviewing stakeholders, there's no mention of talking to patients, which I'm hoping that you're going to include in the stakeholders that you interview.
For sure. So 2 excellent questions. So of course, stigma is a big barrier in Australia to the uptake of just accessing care. Different forms of stigma, so anticipated stigma. So we've talked to different people, different clients that anticipate stigma, so that prevents them from coming in the healthcare system. And there's also enacted stigma that we have found as a barrier, that they are facing stigma when they access some of those services. So that's definitely a barrier for sure. And yes, we're talking. So there's 2 additional groups that I didn't show. So we have, of course, interviews with clients at different sites, interviews with providers and managers at all of those sites as well.
Thanks very much.
Last question in the back, way over there.
Thank you. Great talk.
Oh.
You mentioned a barrier that was in Australia with the complexity of the use of the gene expert system. My team was employed to get FDA approval in the United States for that assay, and they watched a training video. They actually were not allowed to participate if they had laboratory experience, and I will tell you that the recruiters did not hold college degrees. And they were able to accurately detect using that system. So is it a perceived barrier, or they actually found it hard to use?
It's tricky. I mean, the key barrier is often maintaining a sufficient number of trained operators within the setting that are able to competently handle the machine, right? So there's turnover, which influences the fact that we have less people at a given time able to use the machine. So that's a key factor, I think. And it's, it's not too complex, from the operators that we interviewed, but it's still, quite a bit complex, that it requires some skills and knowledge of how to do the QA process, quality control process, and there's also still error, continuing error rates in operating the machines. That those error rates have been brought down by continued training and support, so that's encouraging. But there's still 5 to 10%, I think, at some points, error rates in operating the machine. So yeah, that's also a barrier.
Thank you very much.